I've borrowed this slide from Roman Sale in Luxembourg, who's a leading osteotomist, soon to be president of the European Knee Society. To introduce this topic, we need to understand the context in which knee osteotomies are used. It shows a typical interventional progression following an injury or degenerative process of the knee. You'll notice that an osteotomy is the last option shown in the green repair phase box. The patient retains their native knee, and when we go beyond that point to any form of joint replacement, the knee has been surgically amputated with no option to return. As a trainee, I worked for several knee surgeons who would routinely tell patients that despite their arthritic and painful symptoms, they were too young for a knee replacement. Subsequently, they were told that there was no surgical option. Go home and take painkillers until you're over the age of 60. So this is the key message from my talk. The time has come for younger British patients to question if their surgeon would consider performing an osteotomy rather than a knee replacement. If the surgeon doesn't have the expertise, then the patient should be asking for the opinion of someone who does. Medial opening wedge has become the predominant operation, and this has been enabled by the work of the AO Knee Expert Group, who adopted trauma plating technology to produce the Tomafix plate. And this really is a brand new way of performing osteotomy with a highly sophisticated approach in terms of planning and execution. Many of these leading surgeons attend the UK masterclasses as international faculty. We're getting better at selecting correctly because there's an obvious role in younger symptomatic patients with deformity and partial thickness disease. In addition, osteotomy is now being used to unload patients with cruciate ligament injuries or restorative cartilage procedures. Our indications are constantly expanding to now include young, active patients who are displaying the signs and symptoms of early arthritis, who've perhaps had part of their shock-absorbing meniscal cartilage removed in the past. And that's why, in Germany, 20,000 of these operations are performed every year. Yet in the UK and the US, where this operation is not really well known, we're only doing slightly more than 1,000. Preoperative planning is now mandatory, and this is done with specialised x-rays of the whole leg and computer software for this specific operation. So we've moved into an era where patients will receive a personalised correction for their individual problem. We can rely upon the calculated opening distances during surgery, so live x-ray methods to confirm alignment are becoming historical, and this is leading to greater surgical accuracy. The plate is solid enough to reliably support opening wedges, which means that patients can put their full body weight through it, which facilitates earlier rehabilitation. And recent developments include smaller incisions, less invasive approaches, and infiltration of a cocktail of local anaesthetics into the soft tissues in order to minimise patient discomfort. And this is now an operation which can be performed in 45 minutes to an hour by an expert surgeon. Tibial osteotomy resulted in clinical improvement, with Oxford Knee and Coos scores increasing by 11 and 23 points. A visual analogue scale for pain reduced by 33 points. 87% of patients thought that their osteotomy was at least good, if not very good or excellent. And 87% would undergo the surgery again. So let's put that in context. The 87% of satisfied knee osteotomy patients is greater than the 82% of satisfied knee replacement patients in this large survey conducted by one of my contemporaries, Paul Baker. And let's not forget that osteotomy patients tend to be younger and more active with higher expectations. So in the opinion of patients, 90% felt that they were made better. And when asked, the average satisfaction was 8.2 out of 10.